Kia ora koutou, and welcome to tonight's Goodfellow Unit Webinar on primary prevention of UV radiation, supported by L'Oreal. My name is Dr. Courtney White, and tonight we'll hear from Dr. Monique Mackenzie. Monique is a dermatologist and completed her training in Birmingham in skin cancer care and rare diseases. She's now completing a Mohs micrographic surgical fellowship at the Skin Cancer in Tauranga. Monique is a member of Melanoma New Zealand, the American Academy of Mohs Surgery, and the New Zealand Dermatology Society. And I will now hand over to Monique. Thank you, Monique.
So as Courtney mentioned, this talk is sponsored by L'Oreal, in particular La Roche-Posay, but I'd actually like to extend a thank you to La Roche-Posay and L'Oreal for continuing to support particularly GP education around sun protection. I think it's an important topic, like I said, so thank you to them. So I'm putting my key take-home messages right up the front here because I want you to kind of get at the beginning what I'd like you to take home, and it's basically what I'd like to try and install in my patients that I'm seeing on a daily basis, and that's to keep out of the sun at high UV index times. So we'll go into that in more detail. Using clothing to protect the skin from the sun as a second important way of protecting your skin from UV radiation or seeking shade. And then finally, sunscreen, so SPF factor 50 plus, no less than that. And it does have to be every day to those sun exposed areas on the body. And yes, I do say even in winter, so it's 365 days of the year. On the right there, this is a picture of a place called Omakav. For those of you who may know of the region, this is around the region that I grew up, and also is showing a hoarfrost, so extremes of both cold and warm. So the contents of the presentation this evening, I'm going to go over the relationship of the sun with humans and planet Earth to put it into a wider context, UV radiation types and the effect it has on skin, photoprotection, so protection from that UV radiation, sunscreen specifically. There's been some changes in the legislation recently, which I will cover, different filter types, and some special patient groups, because we think about sun protection in relation to prevention or primary prevention of skin cancers, but actually there's quite a range of patients who we need to be having this talk with specifically, which you may not have thought about, so I'll cover those. So planet Earth is reliant on the sun's existence, and humans' relationship with the sun spans back millions of years, from Inca sun worshippers to our own indigenous stories such as Maui and the sun on the right there. But the sun is central to our gravitational structure on the solar system. It provides our seasons, light and heat for the Earth, and importantly, it provides energy for growth and important cellular structures such as vitamin D synthesis and photosynthesis for plants. How did the sun become so harmful to our skin though? Well, it's a combination of factors from migration, so human migration of fairer skin types from countries that are further away from the equator and moving centrally, our shift from being outdoors all the time and our skin exposed to the elements all the time about 10,000 years ago to living more indoors and of course working indoors. So our skin is more sensitive to the sun when we're outside. Relative hairlessness, of course some more than others, and our change in our climate. It's not actually that the sun's hotter itself, but more energy is trapped within our atmosphere. And that's a combination of the interaction with photons and the atmosphere and the ozone layer, as well as ice cap melting. So large caps of ice are quite reflective for the sun, so it actually reflects it back out beyond the Earth's atmosphere. So with less of that, we have more energy captured within our atmosphere. So this is all really important because it results in skin cancer. And New Zealand has 10 times the rate of skin cancer than anywhere else in the world per capita. So we have very high rate of skin cancer. Approximately 80,000 skin cancers are diagnosed for Kiwis every year. And that equates to about 2,500 people with melanoma, of which 50 of those are Māori. 500 deaths per year from melanoma, and that's more currently than our road traffic accident mortality rate. New research that came out this year, it was a global study across multiple countries, actually showed that in New Zealand, 1 in 20 men over the age of 75 years will develop a melanoma, and 1 in 30 women. So I think when we break it down like that, that's actually quite a stark figure and very concerning. The cost as well, so $130 million per year for skin cancer treatment for the government. That's a relatively recent figure, and estimates are said for that to increase by 50% out in 2040. So what is sunlight? I think it's quite important just to go back again to show you why it is actually so harmful to the skin. So in the center or the core of the sun, there's nuclear hydrogen fusion reactions going on. So 15 million degrees Celsius at the core. And it actually takes 32,000 years for those photons to reach the surface of the sun. So really long time in comparison to the 8 minutes that it takes to travel from the surface of the sun to Earth, about 150 kilometers away. When it reaches the Earth, the radiation is divided up into 3 main UV bands. So that's UVC, which is very high intensity, and thankfully that's actually reflected back and absorbed through our ozone layer, but that's why the ozone layer is so important. Then UVB, only 10% of that actually reaches the Earth's surface, so 90% of that is reflected out from the atmosphere. And mostly, or most of UVA, so lower frequency, slower wavelength, reaches Earth's surface. And you can see on the left, this is just a H&E slide of skin that shows you the lower frequency UVA penetrates deep down into the skin, so through that pink epidermal layer down into the dermis, and then UVB is mostly absorbed into the epidermis with the keratinocytes and along that basal epidermal junction and upper dermis. So thinking about UVB rays specifically, these are more highly energetic. We could see where it penetrates into the skin. And so what happens is it's penetrated into the keratinocytes, and it actually causes formation of thymine cyclobutane dimers, and that results in DNA mutations. It also triggers an inflammatory response, so it's UVB that is triggering bradykinins, which gives us a sensation of pain, sunburn cells adequately named, that gives rise to erythema, and of course melanogenesis. So this is what we would equate to a tan, and it's our body's own protective mechanism to try and protect those skin cells from the sun. When we're much younger, our body's very good at repairing DNA, but as we get older and lose that ability, those DNA mutations become more problematic, and that's where we see the rise of skin cancer. So UVA, slower, longer wavelength, it's penetrating deeper into the skin, but it's really considered to be mostly responsible for skin aging, or we also call that photoaging. It occurs all throughout the day, so there's no peak, which you'll see in a minute, like UVB in that midday period, and it can penetrate through glass. It also causes DNA damage, but it's more associated with oxidative stress and reactive oxidative species, and that causes breakdown of collagen and elastin and results in rhytids or wrinkles. This is just a summary slide, really, where you can see the different UV radiation frequencies. So UVB, it's generating inflammatory and immune responses causing DNA mutations. UVA is more related to oxidative stress, and we're not, thankfully, getting any UVC. So just briefly touching, look, our GPs are absolutely amazing. After working in a couple of different countries, it really made me appreciate how well-trained our GP population is in making diagnosis of skin cancers. So the big three, I call it: basal cell carcinoma, squamous cell carcinoma, and melanoma. This is also quite a famous picture. Most of you have probably seen this before. This is of a truck driver. It was published in 2012, and it shows the side of his face on the left, which is exposed to the windscreen, and the opposite side, which is relatively sun protected. The histology specimens are not from him, but are reflective of the changes here. So you can see on the left, this is completely normal skin, epidermis and dermis. And as you go through, you can see the changes, mainly there in the upper dermis, where you're getting a lot of elastin and collagen breakdown, which is represented in this sort of light purpley color. This is also a relatively not well-known picture. Again, related to photo aging and the effects of the sun. These are twins. On the left, the twin remained and lived in the United Kingdom. On the right, this patient had immigrated to Australia and been living there, and she was also a smoker. But you can see the photo damage, not just rhytid, so wrinkling, but also there's a lot of dyspigmentation, so a lot of brown, solar lentiginous type changes. You're also seeing erythema there as well, and I wouldn't be surprised if she hadn't had one. She would develop a skin cancer at some stage. So why does New Zealand have a particularly high UV index? Well, it's actually quite multifactorial. So yes, it's our latitude, so it's a mid-latitude range, and also altitude as well. We have many areas that are quite high altitude. Thankfully, we have really low levels of pollution, but actually countries with high level pollution have much lower UV indices because it scatters the UV radiation back up through the atmosphere, and cloud cover is an important factor as well. We have, even though Aotearoa is the land of the long white cloud, we actually have a lot of clear sky days, so that contributes. Albedo, which you may or may not be aware of, that's the reflective property of UV radiation from surfaces on the Earth. Because we're surrounded by a lot of water, basically a long skinny country, there's a lot of reflection that comes from water, as well as agricultural kind of dry, arid land and our snow. Kiwis love to be outdoors, which is great, but the more time we spend outside with our skin exposed, the more UV damage we accumulate. And ozone levels is an important factor, and we are closer to the ozone hole, but actually it's now thought to be somewhat overstated, and I'll talk about that in a minute. Oh, yeah. This is Kiwis at the beach, and I have to say we are getting a bit better, but it's always tricky to head down to the beach because there's still many people lie out unprotected. You can see that they're burning. They don't have hats on and just out there enjoying a Kiwi summer. It's a slide on the ozone layer. So, and it was in the 1980s that they were measuring that there was significant damage over Antarctica to the ozone. And as I've shown before, this was important for reflecting back some of those high energy UV radiation wavelengths. Montreal Protocol was brought in 1987, and you can see with the photos, it's just slowly over time gradually got better and improved. There's been subsequent amendments to the Montreal Agreement, but obviously fossil fuels and the impact it has on the atmosphere is still an ongoing issue and having significant impacts on our climate. The relationship specifically to skin cancer, though, is not that clear. So what about UV index? So this was developed in Canada by scientists not that long ago, in 1992, and it's actually quite a complicated computer model where they use erythemal weighted irradiances, which roughly translated is the wavelengths that cause certain levels of erythema on the skin, the zenith angles. So that's a calculation of how close the sun is to any location on Earth. You've got your actual location, but that's just not a pin on a map. That's taking into consideration the latitude, the longitude, and the altitude. And then they actually measure the ozone layers, ozone levels at that location. I don't know what the exact formula is, but those are the variables, and they do change depending on which country you're in, and because they do calculate them slightly differently. But for simplicity's sake, UV index can be basically approximated to the amount of time it will take you to burn or to become red. So that's probably the easier way of thinking of that. The higher number is extreme. On average, New Zealand reaches somewhere between 10 to 13 on the UV index scale in midsummer. So the first take-home message was really to avoid being outside at those high UV index times. So this is typically between 11 o'clock and 3 p.m. And that really can be easily practiced by patients by really looking at the level the sun is in the sky. So when it's up high at midday, that's when it's closest to the earth, and that's when it's going to be at its strongest. As it heads down towards the horizons or coming up from the horizon, there's a much greater distance for the sun or the photons, the lights to travel, and it's a lot weaker. UVA, however, is all day, but as I'd said previously, this is mostly in relation to photo aging, but most of your patients, a lot of them will be considering that as part of their skincare as well. So second take-home point was photoprotection. So after avoiding the sun completely, so trying to schedule your time, your activities on those shoulder sides of midday, clothing is really your next level of best protection. So, and I always say that to patients, it's much better to cover up with clothing. But what type of clothing? So we know that dark clothing, so black clothing over white clothing, is far more sun protective. So something darker, obviously tight weave. So no, people may have worn shirts in the summer and they can actually get burnt through that or develop a tan through that. So making sure the weave's quite tight and that you're covering the exposed areas. So that might be not just clothing as in long sleeve, long pants, but making sure your hat's coming down and covering the back of your neck, covering for the back of your ears and ears in particular, and face. After that is shade, and there's a lot of work that goes into providing shade that provides sort of airflow, but also adequate UV protection, and then UV protected glass for those that are close to glass windows or working in glass buildings. So there's building codes around that, and as well as those who are doing a lot of driving. However, they may not have a choice around that. So coming up with other ways to protect their skin from that UV radiation coming through glass. That might be buying their own shade for the side of the window, or also sometimes we have people wearing like a headscarf, so it wraps around here and covers up their face if they're driving a lot. And then finally, really, it is sunscreens. So for me, sunscreens are the third line. So last resort, if you need to be out, you can't cover an area of skin, you're going to be using sunscreen. And that didn't come up very well, but basically that was a paper in the JAMA, so Journal of American Academy of Dermatology, which directly correlated regular daily sunscreen wearing to reduce rates of melanoma. So there's different types of sunscreens, and I think with ongoing messaging, most people have got this now. So you have chemical filter sunscreens, and then you have physical blocker sunscreens. Chemical filters, there's around 30, and how they work is the UV light comes onto the skin. It's absorbed by that filter. There's a chemical reaction, and it actually reflects that back out from the skin. Often actually you can feel heat as part of that chemical reaction, and that's also useful because that's the body's way of saying, hey, it's getting a bit hot, you need to go inside. Some chemical filters have been in the public awareness, I guess, over the last few years around the Hawaiian sunscreen bill. So currently, and that's related to coral safety. So currently they have oxybenzone, octinate, avobenzone, and octocrylene banned from their sunscreens. But if anyone's planning a holiday to Hawaii, it's best just to buy your sunscreen when you get there. And then physical blockers, which are probably my favorite type of sunscreen. This is just a chemical barrier, and usually they use either zinc oxide or titanium dioxide that sits on the skin, and it physically reflects the UV rays back towards the sun. I guess one of the main issues with the physical blockers is that it can cause the white sheen. So you can have nanoparticle physical blockers where that is reduced, but often your physical blockers will have a tint for that reason to help offset the white sheen for patients who may not like that. So what is SPF? So SPF labeling is very important. We say nothing less than 50 plus. So really you're looking for 50 plus in everything that you buy over the counter. And it's derived from the minimal erythema dose with sunscreen on over minimal erythema dose without sunscreen on. And the number itself is the number of times longer it would take to burn with the sunscreen on. So 50 would be 50 minutes. That's in relation to UVB protection, but UVA protection isn't regulated in the same way. So UVA protection on the labeling on a sunscreen is delineated by the terminology broad spectrum. So broad spectrum means UVA protection, and the UVA protection needs to be at least 1/3 of the labeled SPF. So that's about 17 for SPF 50. So it's not complete. It's also tested in a lab, as unlike UVB, SPF is tested on actual participants and with water testing as well. And then this has become more topical over the last few years, really, is not specifically in relation to skin cancer, but particularly in relation to photoaging, and that's visible light blockers. So visible light is a spectrum that we haven't talked about, but these are the colors that we see from day to day. Again, slower light spectrum, but still coming from the sun, still generated by the sun, and still carries with it photonic energy. It penetrates again even deeper than UVA, but it's mainly related to age-related dyspigmentation. So that might be melasma, that might be little telangiectasias. And why this has become more topical recently is because of the blue, and the blue that comes from our cell phones, from our computers that we're working at all day, our laptops. So the advice is for protection from blue light in particular, then using a tinted sunscreen, which is a non-nanoparticle physical sunscreen that's basically using the tint to offset that white sheen. And usually they would be using iron or titanium dioxides for those pigments. So sunscreen application, it always seems far more than you think it's going to be. 20-minute application before you're actually heading outside. And basically it's a teaspoon for each part of you. So a teaspoon for your arm, teaspoon for each, teaspoon for your leg, each teaspoon for your face, and then 2 for the front, 2 for the back. So it says actually quite a lot. So again, that's why I always go back to clothing and scheduling. It's by far superior way of keeping your sun protected, your skin protected from the sun. I'm going to leave the link below in the YouTube recording of this, but there's a really great video on how to apply your sunscreen, and it potentially could be a good resource to send your patients to. You just need to let them know that it is slightly older and it still has SPF 30 as the sort of labeling on the sunscreen bottle for this video. You have to really reinforce that it's 50 and nothing less. So a couple of changes to the sunscreen standard, which you can read through if you want there, but really in short, what this sunscreen safety standard act that has been passed at the end of last year means is that all our sunscreens have to now meet quite a rigorous testing process, and the sunscreen has to meet the labeling of the product, and there's now quite a hefty fine if they're found not to meet their labeling claims, and they are unable, if they're unable to prove that they've had testing through an independent body. So again, briefly, so SPF, when a bottle says SPF 50 plus, it actually has to be at least 60. So it's at 50 plus is usually more than 50 plus, and you're getting up around 60 at least. Needs to meet the UVA requirements, have any water resistant claims on there, list all the active ingredients and the percentage of those as well. This will take away what we've had in the past, which has been the consumer testing, which has been good, so carried out in 2019 and 2022, which is kind of holding sunscreen making companies accountable to their claims. There are many that failed, but what I have put up here is just the sunscreens that passed those 2 separate consumer tests and rounds of sunscreen testing in New Zealand. So there's a few, and often people do ask which ones I recommend. So the reason I am happy to talk for La Roche-Posay is because it's a really good sunscreen. Cetaphil is quite good for kids. Neutrogena is quite commonly used. Cancer Society, the pediatric one, Avene's good. So there are a few, but we shouldn't need to really consider the testing so much as we have had in the past because of these new laws that have come into place. Right, so special patient groups, there's a few, but the one that is rapidly increasing is solid organ transplant patients. So you'll be seeing these patients coming through more and more. As part of their transplant care, they are entitled to, and sort of nationally trying to meet the requirement for these patients to have an annual skin check. But as many of you know, the funding for public dermatology is sometimes minimal or even absent in some DHB regions. So it's important that you're aware that these patients are very high risk of skin cancer, so over 100-fold. Mostly what they're popping up is squamous cell carcinoma, but really they're at increased risk of any skin cancers, melanomas, Merkel cell, Kaposi sarcomas, so funny ones as well. They require prompt treatment. They require biopsy to differentiate subtypes or aggressive subtypes. And it's really important that they're getting these sun protective messages. Now, I have to just point out on the formulary, they are entitled to funded marine blue sunscreen. Marine blue sunscreen did fail the consumer testing, but given the new standards are now in place, the marine blue sunscreen should meet those requirements. But I dare say there will be a bit of an overlap where there's old stock, and it probably isn't SPF 50. So if you are having patients with that you're seeing and giving advice to, you just need to be mindful of that. But there is no other funded sunscreen apart from marine blue. So that's the big group, but there's a whole bunch of others. So aggravated dermatological conditions, so lupus is the other big one. Lupus is more prominent in Māori and Pacific populations, so not really a population that probably typically think about vigilantly protecting their skin from the sun by covering up and wearing sunscreen on a daily basis. So really important that those messages go to them. Rosacea, that's common, probably 1 in 3 to 4 women with European skin type, increasing with age. Their rosacea is usually absolutely triggered by UV radiation. Melasma is a big one, more common in darker skin types that's very sensitive to photoradiation. And then the melanin deficient patient group, patients with vitiligo, much less common albinism, and then even less common rare conditions like xeroderma pigmentosa or Ferguson-Smith syndrome. But I dare say that several of you have patients with these conditions, so just keeping those in mind. Finally, common phototoxic agents, so not just patients with specific diagnoses that will become more sensitive to the sun, but all the medications that we prescribe that can make you more sensitive to the sun. Common ones, I guess, in general practice would be tetracycline, so doxycycline, minocycline, we don't tend to use as much. The thiazide diuretics or hypertension, hydrochlorothiazide. A couple of our immunosuppressants we use quite a bit as thiopurine, mycophenolate, and the list kind of goes on, but that gives you a bit of an idea there. I just thought I'd put a couple of extra slides in, so extra for experts, but mainly because when I talk about UV photoprotection, I often get a question about vitamin D. So yes, we're wanting people to be vigilantly protected from the sun, but does this mean that then they will be vitamin D deficient? The short answer is no. You get basically enough vitamin D from the sun with 2 minutes of incidental UV exposure. So that's kind of in between the car to work, car to grocery store, car to picking up children, these kinds of things. And I recommend vitamin D sources, so high vitamin D sources in the diet. So fish products, fortified dairy, bread, cereal products, supplementation. But vitamin D is essential to health, and particularly bone health. And chemo prevention, this has always been on the sides a little bit, but I thought it would be worth mentioning. So polypodium leukotomas or fern block through HelioCare. This is a strong antioxidant. It's made of polyphenols, and it has got quite a bit of research now around its ability to reduce sun-related skin damage. It's not recommended. It hasn't come out in new guidelines and hasn't convincingly yet come out showing a robust reduction in skin cancers. However, for us, if we're looking at patients that want to go the extra mile, or they're still wanting to do something else, or they're asking specifically about this product, this is something that absolutely has scientific data behind it, and more to come. Usually we'd be saying 480 milligrams, so taking that 8 hours and then 2 hours before sun exposure. Nicotinamide has been around for a while now. It became very popular when the original study came out from Australia, but now less so. There was an opposing study, and it did find that there was a reduction in all keratinocytic skin cancers as well as actinic keratosis, but unfortunately that effect was not maintained. But occasionally, yeah, we still do put patients, or they try nicotinamide, and that would be 500 milligrams BD. So again, just repeating take-home messages: keep out of the sun at high UV index times, in preference to sunscreen, wearing clothing or seeking shade to protect the skin from the sun. And if you are out and you can't cover up with clothing, then it's SPF, no less than 50 sunscreen to those sun-exposed sites of skin, and including winter. And this is a picture of myself and 2 of my 3 children, and there's my mum in the background, and we're heading out and enjoying the outdoors, but you can rest assured we're pretty well covered up there, and we do have our waterproof sunscreen on. So thanks.
Thank you so much. That was a really, really good overview. Thank you. So we've got some questions that have come through. One was that several years ago, sun protection could be prescribed and fully funded. Are there any situations where this is still the case that you know of?
Absolutely. So any photosensitive dermatoses, so that's mainly going to be lupus in general practice. So you can just put at the bottom, like I said, it's still marine blue sunscreen, but you just write that 50 plus, and then I normally just put in brackets certified condition, and that should be funded for the patient. Your other big patient group now is going to be your solid organ transplant patients. So all of them can get funded marine blue sunscreen.
Someone just wanted to clarify what SPF actually means. Is it how long it protects your skin from the sun, or is it more how much of the UV it stops?
The calculation is based on how much it's protecting your skin from the sun and for how long, but we use it more generically, I guess, than that, where we're just saying our minimum standard is for that protection factor to be 50 plus, which is really 60 in testing and in legislation. So you're getting good protection for an hour of that sunscreen. You may, if you're astute, notice though that the recommendations for sunscreen reapplication is at 2 hours. It's not at 1 hour. So there's still some discrepancies there around what we're saying, and I think this is part of it, just making sure we're all trying to say the same thing, because it does become quite confusing for patients as well when they're being told different, or given different messages.
One more question on the funding, the patient groups. Is someone like with eczema, would they qualify?
Good question. What I would say about that is yes, photoaggravated eczema, so dermatitis, but generally not.
Then a couple of questions about some other specific groups and if you've got any sunscreen recommendations. So you did mention a couple for kids on a previous slide. Any for people with sensitive skin or bad acne?
Bad acne, hands down, La Roche-Posay ultralight fluid. It's super light. It's known to be non-comedogenic. We're treating a lot of acne patients, and I can say I haven't had any issues with that one. The alternate to that is something called SkinCeuticals, but unfortunately we don't yet have it in New Zealand, but that would be my go-to. Now Cetaphil has a sunscreen. Cetaphil has always been a well-known go-to acne over-the-counter brand, so I'd say that would be your second choice. But a lot of sunscreens are quite heavy and quite oily, so your patient will really thank you for a good recommendation. And that's one thing I didn't mention, them with patients being on isotretinoin, absolutely they need to be wearing their sunscreen. Just answering the question about kids. So I didn't touch on this specifically, but it is really important. So sunscreen below the age of 6 months is not recommended at all. So completely off the cards. And this is mainly based on the fact that children under 6 months shouldn't be in the sun, full stop, because their skin is so sensitive. After that, there's actually not that many brands available that go all the way down to 6 months. But the ones that I do know, we should probably have to get online, to be honest. One is HelioCare Pediatrics. So HelioCare I mentioned in relationship to the fern block or the polypodium leukotomas. So that's the company that brought that out. They do a pediatric sunscreen. And there is also another one. It's called Feel Good. I haven't tried this one, but I hear it's trending on TikTok. But I have looked at the specifications for that, and that also is safe to go down. But if I was going to choose for a young child, for myself, I'd go HelioCare Pediatric.
Are there any situations where sunscreen wouldn't be needed? So someone specifically asked around areas of the South Island in winter when the UV index doesn't get very high, like doesn't get over 3, but they do struggle a lot with vitamin D deficiency.
Yeah, I think there are absolutely cases where you don't need as much sun protection. So if we're just talking specifically in New Zealand, and this is in relation to skin cancer, but it doesn't take into consider photoaging or i.e. aging, so sun causing wrinkles and pigment issues. Very dark skin type, so I'm talking skin type kind of 6. They don't really need sunscreen in these scenarios at low UV index times. For our typical kind of 2s and 3s for skin types, so fairer skin types, sunscreen every day, 365 days of the year, even in winter, even when the UV index is low. And that's based on the level of risk to our patients, because we have such a high risk. And we all know out on a winter's day might be very cold in the morning. You think, okay, going out, you get caught outside, and the cool weather falsely represents the amount of UV that's in the atmosphere. So when it's cold in winter, you're not getting that same heat kind of sensation because it's cooling you down. A bit like when you're on the ski field, I guess, where it's freezing, but actually you're getting a whole lot of radiation on your face, but you're just not registering that as pain or redness.
Thank you. Someone's mentioned that nicotinamide can cause a type of retinopathy. And so for that, would you prescribe it for a period of time and then stop it? Or is it quite unusual to come across that?
I haven't personally come across that, and I don't personally prescribe, or it's not a prescription, but recommend nicotinamide. Often you'll mostly find patients on this as an overhang from the research that came out in Australia. So what I say is to patients now, if you haven't noticed a reduction in the frequency of skin cancers, so that's keratinocytic, so basal squamous cell, actinic keratosis, then you know, it's probably not making a discernible difference. You're spending a heck of a lot of money paying for that to take that. You're probably better off just making sure you're putting sunscreen on every day and buying that. Yeah. So I think if you've got concerns, you would stop it because the evidence is just not really there to continue it.
Yeah. Is there anything you can do once you have been sunburned, like for symptoms of the skin burn or to protect the skin after the fact?
That's actually a good question. Maybe I'll add that in next time. But yeah, because that's the obvious thing, right? Whoops, we kind of got caught out and we got burnt. So you can use topical steroid cream, and that works really well. You just have to be mindful of what potency and what location you're putting your steroid cream on. So obviously for the face, you don't want to go above something like a Ristocord, but for the body, it'd be quite safe to use a bit of Alicon or Beta 0.1%. The sooner you can get that on, the better, honestly, and it will really help with sunburn. So for a couple of days thereafter.
And that's more for the symptom of it, or would it help?
Yeah, no, more for the symptom of that. So just reducing the inflammation, and that's going to reduce your pain. In terms of once the damage has already been there, you've accumulated that damage. Not really. There's not any studies that have looked into after sunburn. Is there anything that you can take that reduces the risk after that and it would be really hard to actually design a study to figure that out. But I think with the supplements that are covered, polypodium leukotomas, that's one of those where it's a chemo preventative. So, but we're not quite at the point where we're using something after the fact and after we've got burnt.
Would you be able to talk a little bit about the prescribed UV treatment that dermatologists use? And also a common question is the UV lamps in like nail salons. Is there any risk with those?
Yeah, that's a good one too. So I'll answer the one about the UV lamps in nail salons. So yes, patients should be putting sunscreen on their hands before they're putting their hands under the light. So there's been quite stark pictures of hands before and after, repeated treatments, I guess, at the nail bar that go under UV light. So that will cause mostly photo damage. The UV light that we use in phototherapy booths, it does vary, but most of the time it's narrowband UVB, but it's very specific. So it only covers, so out of the narrowband UVB spectrum, so that entire wavelength, it is at the lower end of the narrowband UVB spectrum, and it's for an extremely short period of time. So a patient's normally in there for well under a minute, and that time is slowly accumulated. Lots of studies around UVB as a therapy, long-term effects, long-term risk of skin cancers. And yes, it is slightly increased, but it's marginal. So we've got to the point in dermatology where we don't specifically talk about narrowband UVB treatment as particularly increasing your risk of skin cancer. That's quite different, however, for PUVA. So that's using UVA with psoralen. That's got quite a high risk. Most patients will develop skin cancer if they've had repetitive treatments of PUVA, but we don't use PUVA very often now because we have other medications available. So you can reassure patients it's safe. Previous skin cancer, such as a melanoma, is a relative contraindication, but not an absolute, but you would need to discuss that with a dermatologist. Keratinocytic skin cancers, that's tricky because so many patients, or 1 in 3, 1 in 4 patients will have actinic change over about the age of 60. So this is where you sort of need to use common sense as well. You need to look at the patient as a whole. Are they on any photosensitizing medications like antihypertensive medicines? Can you just sort of cover their face where they mainly have their actinic damage and you're just treating where the eczema or psoriasis is, which might be their body or their limbs? So again, that's kind of getting into probably specialist territory, but hopefully, yeah, that answers the question.
Great, thank you. And sort of related, is there any UV risk for welders?
Welders, yes.
Mm.
Any occupation where photons as an energy, so light energy, is in close contact or repetitive contact with the skin, absolutely. So we often see welders with facial skin cancers, particularly those older ones that not used their, or they didn't have those regulations, I guess, at that time, their facial shields.
Regarding the dark clothing recommendation, what's the benefit of the dark over the light? Is it reflecting the UV?
Yeah, this is a good question too. So it's absorbing the UV. Yeah, whereas the white will let it go through.
Question about sunblock. Someone's heard some concerns about the sunblock chemicals being absorbed systemically and possibly some risk from those. Would you be able to comment on that?
Absolutely. So this often comes up with patients and from the chemicals themselves and absorbing systemically to nanoparticles and the absorption of nanoparticles for physical blockers. They have looked at this multiple times, and some chemical blockers are minimally absorbed into the systemic system, which is why personally I do quite like physical blockers. But there's been no correlation with any adverse effects or toxicity. So yeah, there is inevitably going to be a little bit of absorption. It's minimal, and it hasn't been shown to be related or correlate to any adverse health outcomes. So that would normally be my go-to line for patients that have concern, or just saying, okay, well, if it's an issue for you, let's have a look at what physical sunscreen blockers are out there that may work for you.
And someone's asking if there's any risk with LED infrared treatments for acne and aging, things like that.
Absolutely. Light is light. Yeah. Any light, if you can see it, it's light, and it's going to affect your skin, particularly with repeated treatments. So yeah, we do use lights, so laser lights and LED lights, to treat certain types of skin conditions, but it's quite specific and it's super targeted. So treating, I just wouldn't treat with a home LED, because you're putting light continuously on your skin. That light is going to be absorbed into the skin. That's going to be breaking down really important fibers in the skin, collagen, elastin. It's going to be triggering off pigmentation. So sure, red light, LED light, that's absorbed by red, so it can help with red. But what about the brown that it's going to cause? So yeah, I would just stay away from those unless you're doing something specific with your lights under specialist guidance.
Are there any physical blocking sunscreen like brands that you would recommend?
They're a little bit harder to find, and I'm still on the lookout for my perfect sunscreen. I've collated a massive list for all sorts of different ages, types, what people are looking for. Physical sunscreen. Invisible zinc's not bad as a physical blocker if you really need something high protective, like you are at the beach and there's going to be sand and there's going to be water. It has a lot of white light reflection that comes off that particular sunscreen. And annoyingly, it did fail the consumer testing, though again, that shouldn't be an issue with the new legislation. And part of that failing was related to SPF 50 having to actually be 60. So anything that didn't meet that criteria failed, but they might have still actually met the SPF 50. Zinc is fine. There's a good surfing sunscreen, which is physical, which is called Sol. So that was on the presentation. But again, it's having a look and trying to find one that suits you. Less ingredients on the back is always more when it comes to physical sunscreen blockers.
Got a question that's slightly off topic. Retinoic acid, we did mention, of course, that it increases your risk of sunburn and sun damage. Someone's asked if it helps with wrinkles.
It does, and the way that it does that is by increasing cell turnover. And so you're really rejuvenating the skin to a more youthful cell differentiation rate. So those new cells coming all the way up to the top and the old ones kind of falling off really. So that helps with that. We all know probably that Retrieve is subsidized. And so I am quite happy to prescribe my patients Retrieve cream for that purpose, or it works really well if you've got that actinic patient, lots of field change, so just lots of kind of scaliness happening. They can apply that 2 or 3 nights of the week, apply it to the backs of their hands. It's not magic. It's not going to stop those actinic keratoses from appearing, but it's going to slow them down and it's going to keep the skin a lot smoother. So often we do prescribe that in relation to just general management of our skin cancer patients. You can also use that prior to Effudix treatment, so you can get them to use that for a week or two. That helps reduce the scale down, and then you can prescribe your Effudix or get them to use Effudix Divinex cream.
Someone's asking about the safety of sunscreen again, specifically about nanoparticles in sunscreen, if they're safe.
Yeah, so again, it's a bit like the nanos, a bit like the chemical sunscreen, where the nanoparticles have been shown to absorb down into the skin and into the bloodstream, but at extremely low levels and not shown to have any harmful effects. So yes, it does get absorbed. No, as far as we're aware, it doesn't have any adverse health outcomes. If a patient's particularly stuck around that, again, that's where I go back to physical sunscreens, but you just need to check on the labeling. So you often see me at Chemist Warehouse. It's great because they have such a big selection. Just turning over all the different sunscreens, having a look, you are not looking for something that's not nanoparticle, and that will always say on the back there if it's a nanoparticle or not. So if there's an issue with that, you just want straight standard titanium dioxide. It's as good as anything.
Thank you. In terms of the tinted moisturizers, I think you mentioned those as a bit of a physical barrier for like the blue light from our computer screens and things. Someone's asked, like the BB creams and the CC creams that are out there are often only SPF 30.
Yes.
Can you combine another base kind of thing and bump up your SPF protection?
Yes.
Or is there a tinted moisturizer out there?
Yeah, I think this is a really important question. It's really relevant. There's a lot of makeup out there now that has some kind of level of SPF factor in it, but actually there's not very much that has SPF factor 50 plus. There is a range called ultraviolet. So if you're really kind of looking for something to use as a foundation essentially, and having that high level of sun protection factor, that would be that you'd have to buy that online, but it's available from Australia, and they have an excellent color range as well. No, they're not paying me, but maybe they should. And so that would be one thing, but layering. So your something ultralight, like La Roche-Posay ultralight fluid, that's great because it is light. You can pop that on, it's almost immediately absorbed, and then you can apply your sunscreen, your makeup over top of that. The other thing though that's coming up more recently is, I've got a face of makeup on and it's been like 4 hours and I need to do some kind of reapplication for SPF. So what you can get now is also SPF factor 50 sprays that you can just spray over top of your makeup. It's not going to move it and it will set. And I think those are actually a really good idea. So in New Zealand, we have, I think Neutrogena has a spray, not specifically for that, but you could use something like that to reapply without destroying your makeup. Or again, ultraviolet has one as well where you can spray over top.
And someone's asked if topical nicotinamide is helpful for sun damage or actinic keratoses. They've come across the brand Solar Care B3.
Yeah, so nicotinamide absolutely has antioxidant properties to that. Does it come out in the scientific literature around dyspigmentation? No, is what I would say. But it does have efficacy, which has come out recently in some European guidelines around its anti-inflammatory properties with acne. So that is really the only place that I would otherwise put nicotinamide as an adjunct treatment for acne.
Any recommendations for sun protection around the eyes?
Again, I think if you're going with products or brands that are well known for being or tested and marketed for sensitive skin, so those brands for a dermatologist really are, again, La Roche-Posay, Cetaphil, and Avene. Another quite good brand is something called Prepara, but again, that's only available in Australia, and you'd have to buy that online, but it's a dermatology developed brand just specific for Australia, but it's a really good one, and they have really good sunscreens as well as a tinted sunscreen. So maybe I could leave the link to that. It's a bit tricky. You have to know what you're looking for on that website, because there's a lot of just generic looking products, but they have a few really good ones, including their sunscreens.
Great, thank you so much. Well, we'll wrap up there. Thank you so much again to Monique for her time and expertise tonight. To all the audience, thank you so much for joining us tonight. So thank you everyone, and have a lovely rest of your night.